afternoon to all our participants. This is Cha Orhalo speaking on behalf of the UP Med Class 94 webinar team. The UP Med webinar series is an initiative of the University of the Philippines Medical Alumni Society. It delves on important current and emerging medical topics and is targeted for physicians, especially general practitioners, occupational and industrial health MDs, primary care physicians, family and community medicine physicians, and other health workers. It is held every Wednesday from 12 noon to 1 p.m. Manila time, and registration is free. This webinar runs on the UP Manila live streaming platform at livestream.upm.edu.ph. If you have difficulties in accessing the webinar through the live stream page, please watch the live video on our Facebook page. This session will run for an hour with 30 to 45 minutes allotted for a lecture, followed by a question and answer portion. To participate in the webinar, please use the Q&A box found on the live stream page. For Facebook participants, please type your questions in the comments box. Please only use the comment section for questions and other webinar concerns. An evaluation link will be emailed to you after the webinar. Please answer it to get a copy of your certificate. May we now call on Dr. Hazel Reyes, who is a member of the celebrating class of UPCM 1994 and is Associate Professor of the UP-PGH Department of Medicine Section of Rheumatology and is the Assistant to the Associate Dean for Academics. Dr. Reyes.
Good afternoon, Cha. Thank you for that. Again, this is Hazel Manapat Reyes. Our time now is 12:03, and I'm speaking from the IMS building, Padre Faura Street, Ermita, Manila. Today's webinar is entitled Tuberculosis and Diabetes. Our objectives for today's webinar are, first, to discuss the association between diabetes and tuberculosis. 2, to analyze the implications of this association for the prognosis of TB. And number 3, to present the current guidelines for the diagnosis and treatment of diabetes among individuals with TB. Joining us again for another webinar is Dr. Cecilia Jimeno, who is also the head for the UP Med Webinars 2019. Cec is a graduate of the UP College of Medicine class of 1994. She finished her residency training in internal medicine and fellowship in adult endocrinology at the UP-PGH Department of Medicine. At present, she's a professor and the chair of the Department of Pharmacology and Toxicology, UP College of Medicine, and a clinical professor at the UP-PGH Department of Medicine Section of Endocrinology, Diabetes, and Metabolism. She's a member of the Department of Health Formulary Executive Committee, a past president of the Philippine Society of Endocrinology, Diabetes, and Metabolism from 2013 to 2015, and is currently the vice editor of the Journal of the ASEAN Federation of Endocrine Societies. Let us now welcome Dr. Cecil Jimeno.
Okay. Thank you, Hayes, for that very generous introduction. So the title of today's webinar is Tuberculosis and Diabetes. Our objectives have been given, but I wanted to also add the fourth one, to outline the treatment of TB among persons with diabetes. I know I'm an endocrinologist, and that's really not my strong suit to talk about it, but I will really just try to give a brief outline of the treatment even of TB among persons with diabetes. The references for this talk include the following. The first is the National TB Control Program Manual of Procedures, and you can download it from that URL. We also included the international standards for tuberculosis care, and of course, the clinical practice guidelines for the diagnosis, treatment, prevention, and control of TB, which was updated in the 2015, of which we had really an opportunity to participate in the Philippine Society of Endocrinology, Diabetes, and Metabolism because of the interest in the association between TB and diabetes. We will go briefly to epidemiology just to tell us that in 2017, almost 500,000 people had TB, fell ill with TB, of which there were around 27,000 deaths. And the good thing is that if you are then diagnosed to have TB in the Philippines, the success rate is now 90%. The problem is that TB treatment coverage, even in 2017, is just 55%. So imagine if you can get this 55% up to 100%, we will then really be able to end TB and achieve the operational targets by 2025. On the other hand, our statistics on diabetes, this is taken from the International Diabetes Federation, shows that we have more or less a 6% prevalence of diabetes, but we know that in the national survey, it was closer to 7%, or it exceeded 7% of the adult population. That's totaling to more than 3 million people with diabetes. Or in fact, if we follow this higher prevalence, that's going to be more than 4 million people with diabetes. Now, this diabetes led to around 56,000 deaths. That was in, I think, 2015 that is projected here. Imagine, therefore, if you have a fairly common disease, that's diabetes, almost 1 in 10 adult individual has either diabetes or prediabetes. And then take another fairly common disease, which is TB, and they would happen together. What would happen to you if you had that? So for that, we'll take a look at the 2015 Philippine Practice Guidelines on TB. It was updated at that time. And we'll first go through the recommendations for pre-treatment clinical evaluation for persons diagnosed with TB. So you already know, for example, that they have TB. What are the baseline tests that you need to take? So the first recommendation was that baseline testing for liver tests, so serum alanine aminotransferase or ALT, and serum creatinine. In resource-limited settings, if you cannot do this routinely, at least it should be requested for all patients older than 60 years old, and even if younger, if they have risk factors for liver or kidney disease, then you need to take ALT and serum creatinine. And then all patients should then be taught how to recognize symptoms of common adverse effects and to consult if they develop such problems. So it's not easy to treat TB because you really have to inform them of all the adverse drug reactions and monitor. Now, one of the more important recommendations at that time is have to do with people who are considered to be immunocompromised or considered to be at risk for TB or its worsening. And therefore, part of the recommendations really included these statements that all patients with history of high-risk behavior for HIV or coming from areas with high prevalence of HIV should be offered provider-initiated counseling and testing for HIV. And as well, screening for diabetes mellitus is recommended for all patients with TB, adult patients with TB, so that proper management of the glucose levels can be done because it is essential to the outcomes of tuberculosis. On the other hand, one of the recommendations also is not to do routine serum uric acid testing because even if they had asymptomatic hyperuricemia, it's not really an indication to discontinue the use of pyrazinamide. And so why do we have to screen for diabetes every time we find an adult with TB? The first is because it's thought that having diabetes actually increases the risk of having TB at least 3-fold. And the bottom line, therefore, based on these studies, is that if you have undiagnosed, even if they're asymptomatic diabetes, it can actually then make you immunocompromised. And then, therefore, this can lead to the development of tuberculosis. The other is that poor glycemic control thus increase the risk for poorer outcomes among those with TB. And one of these outcomes is, for example, the sputum negativity. And in this study, I think this was in Indonesia, they found that after 2 months, the result of the sputum microscopic examination was more often positive in the diabetic individual who had TB, which is 18%, versus those who did not have diabetes. And then after 6 months, 22% of the cultured specimens from diabetics was still positive for TB. So really, poor glycemic control increases the risk of poor outcomes, and this includes the sputum, persistent sputum positivity, as well as an increased risk for relapse, an increased risk of death among those with tuberculosis. and an increased risk of both treatment failure and death, up to a relative risk of 1.69. There is, however, no strong evidence that having diabetes concurrently with TB increases the recurrence rate for drug-resistant strains and even delayed sputum conversion based on this study. However, this is US study actually. Now, we've also found that diabetes prevalence seems to be higher among patients with tuberculosis than in the general population. The idea being having TB, which is an infection, increases insulin resistance, and by itself is now a risk factor for development of diabetes. So the bottom line is having TB might actually increase your risk for diabetes, or at least for hyperglycemia. And we find this, where's the evidence for this? We found some studies, some prevalence studies, for example, in India, where they found that practically 35% of all persons with TB had diabetes. In Malaysia, it was around 17.7%, in Indonesia, around 15%, and in Thailand, very similar numbers, anywhere from 15 to 18%. And when a study, although this is smallish, was done in our own Quezon Institute, Philippine Tuberculosis Society Incorporated TB.Center, it was found to be 18%, very close to our ASEAN neighbors. And it's also important to recognize that there is significant prevalence of both of these conditions in the Philippines, especially in the age group when they do coincide, and this is in the more than 40 years old age group. So how should we screen? So we're saying if you find someone with TB, always screen them for diabetes. Always do lab tests. And which lab test should we do? No, it's the same old reliable test that we've always used for diabetes: FBS for symptomatic individuals, random blood sugar, and even an OGTT. Now, this recommendation for people with TB is different from the general population, because in the general population, you needed to have a metabolic or a cardiovascular risk factor for you to be screened. So, for example, you needed to be more than 40 years old, you needed to be obese, overweight, you needed to have had stroke, etc., coronary artery disease. But now we've added TB as one of the qualifiers for getting screening for diabetes, along with conditions like psychiatric diseases, schizophrenia, for which you need treatment. And in fact, we're adding on even certain rheumatologic diseases. So for example, if you have psoriasis or rheumatoid arthritis, you should also get screening for diabetes. The same, if you have TB, you should get screening for diabetes. Now, having said that, which are the tests which we don't recommend as of yet? We don't recommend yet routinely the use of these tests like capillary blood glucose, fructosamine, urinalysis even, because of the low sensitivity for diagnosis. A1C, though, is being used, and it's actually recommended internationally to be used for diagnosis of diabetes. But in the Philippines, we don't recommend it yet routinely, unless you're practicing in a tertiary hospital where you are certain that the method that is being used is standardized by the method that is being used is consistent with the methods used by the National Glycosylation Standardization Program, Glycosylated Hemoglobin Standardization Program, then yes, you may use it. But if you are uncertain about the method of your A1C, then it's better not to use it. However, if the result is available upon consultation, it should be interpreted with caution, and if possible, then do one of the three tests that I've actually already enumerated. So FBS, OGTT, or a random blood glucose if it's possible. Now, if you then find diabetes among those with TB, how will you treat them? And here I've said already that maybe we need to use insulin more, we need to use combination therapy more, because glucose control for individuals with diabetes and TB should be optimal. And I've said that over and over again. Good glycemic control is important in order that TB will be well treated, that the outcomes will be optimal. And if you're therefore unable to control the blood sugar, a referral to a specialist might even be warranted to control it better. And we made a strong recommendation on that. What are the targets? The same as the regular targets for persons with diabetes. Aim for an A1C less than 7. Aim for an FBS, if possible, less than 100, as close to normal as possible, because poor glucose control increases the risk for poor outcomes. So again, for every increase in the A1C of 1%, there was a hazard ratio of 1.39 or 1.4 with association with the occurrence of TB. And the risk of TB is even higher among those patients already on insulin. So this doesn't mean to say that insulin by itself is bad. It's just saying that people who were in this study were probably on insulin because they were poorly controlled. And because their diabetes is poorly controlled, they had a greater risk of development of TB. Now, a lot of the centers, a lot of our health centers, I know, don't even get to do A1C. So what can you do to try to reach that A1C target? I always tell my students, if you want to reach this A1C of less than 7, try to go under the diagnostic criteria for FBS or for random blood sugar. And what is the diagnostic criterion for diabetes for FBS? It's 126. If you can go under 126 all the time, you probably can reach A1C less than 7. And if you're monitoring the 2-hour postprandial blood sugar, if you can go under 200 all the time, so that's why there's that range, you'll probably hit the less than 7. Now, among those who are younger, among those who don't have any complications yet, they are very low risk for hypoglycemia. You can even hit 6.5. And how to reach 6.5? You try to work at the normal blood sugar. And normal blood sugar is a fasting less than 100 or a 2-hour less than 140. So if you can try to reach the normal blood sugars, you'll hit 6.5. If you try to hit just under the diagnostic criterion or criteria for diabetes, you'll hit less than 7. Now, to optimize blood sugar control, you need, of course, to take a baseline FBS and, if possible, an A1C, so that during the first visit, you can assess the level of glucose control. If the glucose control is good upon first consult, then whatever were the current oral anti-diabetic agents the patient were on, just continue them. However, that's more of a fairy tale than reality. For many of our patients, they come to us already with very high sugars. And because we're running after time, we would love for them to be on insulin therapy to achieve optimal glucose control. So why the preference for insulin and not the oral agents? It's mainly because it's been known that certain of the oral antidiabetics interact with the anti-TB medication. So for example, rifampicin accelerates the metabolism of the sulfonylureas. Those are the gliides, glycoside, glimepiride, glipizide, and the biguanide metformin. So that if you're on rifampicin, it will lower the plasma levels of these drugs and therefore may lead to hyperglycemia. So the treatment might not be optimal. Isoniazid also antagonizes the effect of sulfonylureas. It also impairs the release and action of insulin, leading to hyperglycemia actually even in non-diabetics. No? So you already have TB. TB by itself will increase your sugar because it's an infection causing hyperglycemia, insulin resistance, then hyperglycemia. The drugs themselves can actually lead to hyperglycemia. And therefore, that's the reason why we would prefer that patients would be on insulin, at least during the intensive phase of TB treatment. Preferably, though, we would want them to be on insulin throughout the course of TB treatment to optimize blood sugar control. Now, what if you then control their sugar and then they come back, the patient is already sputum negative or culture negative? Then based on your discretion, if you started on insulin, yes, you may shift them back to oral agents. Just because you gave them insulin doesn't mean that you cannot shift them back to oral agents. Yes, you can do that. However, if you can agree with the patient for them to stay on insulins just so that they maintain good glycemic control throughout the treatment, then that would be preferred. And therefore, if you're not adept at using insulin to control blood sugar, a referral to a specialist would actually really be ideal. Now, these are the lists of anti-diabetic agents that we have in the market. What is in the formulary only is glycoside and metformin. And of course, all the human insulins, there are in the formulary. So what I'm saying is, if you can't give insulin or the patients do not want to be on insulin, try to give combinations of drugs to achieve optimal glycemic control. Now, if you've ever attended a lecture on diabetes and drugs, you've probably seen this very complicated new decision cycles. All that it's saying is that we, of course, when we set our goals for treatment, patients need to, persons with diabetes need to realize that we are doing it because we are moving towards not only hitting a certain number, but because we really want to prevent complications. So in TB, for example, we really want the TB to be cured, and part of curing the TB or part of solving the problem of TB is really for them to get better glycemic control so that they're able to then recover fully from TB. Now, of course, we do know that the use of certain drugs like insulin, for example, is not always optimal. And so we need to have a long conversation with them to agree on the management plan, how they should be monitored. Are they able to even afford glucometer? And if not, where can they go for monitoring? So all these are issues that need to be discussed with patients in order that the treatment for both TB and diabetes will be optimal. Now, we'd also like our listeners or our viewers to know that there is now a strong push in the Department of Health for really the DOT centers to also become equipped, and cross links with the diabetes center, because we need to be able to have those frontline people interact with each other so that we optimally control both diabetes and TB. Now, just briefly, this is from the Philippine Practice Guidelines for Diabetes. If you find someone with diabetes and their sugars are quite high, like I said, insulin is preferred. But if not, then maybe we can give combination oral agents. Now, if their sugars are low, maybe they're just above the diagnostic criterion, monotherapy with metformin would probably be good enough. But if they're higher, maybe the sugars are above 8, they're closer to 9, or they're already near 200s or above 200s, then really combination therapy is something that has to be then discussed with the patient. Now, how we rationalize what we do will depend on the baseline. That's why we're always saying, if you have TB, get baseline test, get baseline FBS, get baseline A1C, because that will be the basis for what we start. So if you then find someone with very high sugars, we have no choice. You either use insulin or combination oral agents. But if, on the other hand, the sugars are not that high, and we know that, for example, the frontline metformin or even the secretagogues can lower the sugar as much as 1 to 2%, then one or both might be good enough. But again, consider that in tuberculosis, like I said, the TB drugs do interact with metformin and secretagogues. And therefore, we need to be adept also at trying to then use the other drugs that are out there, like, for example, combining metformin with pioglitazone. This advantage of pio is that it does lead to a durable effect. It's relatively cheap, but the effect is delayed. Before you get the optimal effect of pioglitazone, it will be probably 6 to 8 weeks. We don't have that much time. And of course, it will cause some weight gain, which might be ideal for some people with TB. DPP-4 inhibitors and metformin, this is a good enough combination. They're weight neutral. They may even cause some weight loss. Very minimal ADRs, but for some, there are cost considerations. Finally, the newer drugs, the SGLT2 inhibitors, you may combine them with metformin, and for some, they actually like it because of the weight loss, but it tends to have more ADRs, no? The tendency to develop genital infections, there is some fracture risk, even some hypotension. These need to be considered when prescribing these drugs. And that's why over and over again, you'll hear me say, we need to use insulin more, we need to use combination more, but especially for this subgroup who have tuberculosis. Now, how to start basal insulin? Very simply, I know it's a bit small, but up there, how to start basal insulin? Basal insulin is NPH, or intermediate acting human insulin, or the newer long-acting insulins like Glargine or Detimir. You only have to remember one number, and that's 10. If you can't remember the 0.1 or 0.2 unit per kilo, just remember 10. That's supported by clinical trials. Just start them on 10. So metformin during the day, or a combination of oral agents during the day, and at bedtime, 10 units. And then you just monitor their blood sugar. You monitor their fasting blood sugar. You take their capillaries in the morning. If they're not hitting the target, add 1 or 2. No? Now here, the titration algorithm is a bit toxic. It says 2 to 4 units once or twice weekly to reach the FPG target. So many numbers to remember. I just like to remember one number, and that's 1. And what does that mean? If you can check your sugar once a day or once a week before eating breakfast, maybe capillary or fasting. And then if you're off target, let's say you're above 100, so 100, you just need to increase by 1 unit every day or every week until you hit the target. And when you hit the target, stay there. So I think that's simple enough for people to remember. If you don't have capillary testing, like an FBS, if you have capillary testing, do it as often as you can. And if you're not hitting the target, add 1. Add 1 every time you're not hitting the target. Eventually, you will reach the target. So we're done with diabetes. How about treating TB among persons with diabetes? Should I change the treatment regimen just because they seem sicker? Should I treat them the same as the general population? Which one of these different combinations should I pick? And there is a consensus on that, and that's well supported also by the International Union Against TB and Lung Diseases and the WHO, that the treatment of TB among persons with diabetes is the same as the general population. There is insufficient evidence to support changing the recommended standard TB treatment regimens or making specific recommendations for clinical case management of TB in people with diabetes. And in Taiwan, when they did a study taking a look at TB in the DOT setting, looking at persons with diabetes, they found out that whether they gave 6 months or 9 months, the outcome was the same. So why pick 9 months when 6 months works as well as 9 months? And that's also echoed by the international standards for TB. And here it says that the initial phase should consist of 2 months of isoniazid, rifampicin, PZA, and ethambutol, and it's down there. Here, if this is a new or no previous or less than 1 month previous TB treatment, it's pulmonary and even extra pulmonary except for CNS, bones, and joints. It's the same old regimen, 2 HRZE and 4 HR as continuation for a total of 6 months. Now, we also want a patient-centered approach. No? While DOT is, or directly observed treatment, is something that we would like to do, it needs to be patient-centered. So that we need to discuss with the patient where it's best to do the DOT. Is it better, for example, in the public-private partnership? Is it better for him to follow up with his own private doctor? Is it better for him to go to one of our public dot center? The idea is if the patient is unable, we need to modify and improve access, especially for the debilitated or the bedridden. If it conflicts, for example, with their work and school, we need to take that into account. And even for young children, how do we then try to modify their directly observed treatment to be responsive to the patient's needs? Now, something new also in TB is now there's now a requirement for registration of certain groups. So we need to register them either in the DOT center. There's apparently a registration even among those in the public-private partnership, even among pulmonologists in their clinics. No, they have this registration forms where we now inform I think the PhilCat of these, no, not PhilCat, the DOH, no, of all of these TB groups. Those who are newly diagnosed, those who have relapsed, those who are being treated after failure, those who are being treated after loss to follow-up or previous treatment with unknown outcomes. Because you'll also encounter that among our patients, no? And among persons with diabetes, therefore, what if they had previous treatment because you told them it's important to treat both diabetes and TB, and then they defaulted, but now they're coming back for retreatment? How should then they be treated? Should I then give a stronger treatment knowing that they're retreatment? And here we do have this updated treatment regimens that have been provided also by the Philippine practice guideline. And for our patient, let's say diabetes requiring retreatment, most persons with diabetes are probably drug susceptible, and so they fall within this category, and they will probably require this form of treatment: 2 HRZs, 1 HRZ, and 5 HRE if they are requiring retreatment. So they're much the same as actually anyone who is going to be retreated for TB or extrapulmonary TB that's not in the CNS, bones, or joints. They should receive this form of treatment. Now, the second to the last issue today is about latent TB. And I'd like to thank Dr. Camilo Roa for actually giving a very good lecture on this yesterday. And I had borrowed a few of his slides. And latent TB is important and it's defined as a state of persistent immune response to stimulation by MTB antigens with no evidence of clinically manifest active TB, meaning they already have the infection, but they're asymptomatic. And the question, therefore, since they're not symptomatic, should we treat them? No? There is also no gold standard test to diagnose LTBI, and there are many considerations when we treat them. What is the probability of progression? Is it more common among specific risk groups? And they do have answers to that. Apparently, children less than 5 years old are the highest risk group, when exposed to people with active TB. They may be asymptomatic, but they probably will need treatment. What is the epidemiology and burden of TB? And that's a determinant on whether we treat latent TB, the availability of resources, and the likelihood of a broad public health impact. If we then try to treat latent TB infection, will you decrease the number who have active TB? And the definite answer is yes. Even if not all individuals infected with MTB do develop active TB, the estimated lifetime risks of an individual with latent TB infection to progress to active TB is around 5 to 10%. So they're like a reservoir of people who can go into active TB. And part of, therefore, trying to decrease our prevalence or incidence of active TB in the Philippines and in many countries is to also treat people with LTBI, and especially among children who are less than 5 years and among people with compromised immunity. Now, because these preventive treatments entail risks and costs, it should be selectively targeted. So not just about everyone needs to be treated. We select who needs treatment, and who are these. First, mandatory treatment. You don't even need to test them among child contacts less than 5 years old. So if you have an active TB, a person with active TB in the family or in the household, and you have a child less than 5 years old, that child probably needs prophylaxis or treatment for LTBI. Persons living with HIV also, they don't even need to be tested. They can be treated for LTBI. All the rest of the risk groups should be systematically tested. If they're positive, then they will need treatment. And which are these additional risk groups? The household contacts who are older than 5 years, they need to be tested before treatment. And MDR-TB, anyone in the household contacts. And the additional risk groups who must be systematically tested for LTBI before treatment, again, the household contacts, but not the following. Here, because initially we already said that all persons with HIV should be treated even without screening for LTBI. Here it's saying that if you are considered to be a clinical risk group, but you don't have HIV. So because automatically if you have HIV, you go to the previous category, but you will need treatment, anti-TNF treatment, or persons undergoing dialysis, or you will undergo organ or hematologic transplantation, even the uncommon patients with silicosis, they need to be screened, no? And if they're positive, they need to be treated. And so we go back to our topic. My topic is diabetes. Here it says, systematic testing for LTBI is not recommended for people with diabetes, people with harmful alcohol use, tobacco smokers, and underweight people, unless they're already included in the above recommendation. So if they have diabetes, but they are undergoing dialysis, yes, screen them. If they're diabetes, you also have HIV, of course, treat them. No? So again, you go back to the previous categories. But if it's just diabetes, it's just really excessive alcohol or tobacco use, there is no recommendation. It's not recommended for you to get screening for LTBI. So just the summary of that, here it says that there is positive data from clinical trials on the benefits and harms of systematic LTBI testing for these groups of people. And therefore, the recommendation is not to routinely test them at the moment. And if you do decide to test, their consensus is that you can either use tuberculin skin test or the interferon gamma release assay or the IGRA to test for LTBI. They're very similar in terms of their sensitivity, and therefore it just begs the question of access and cost of these screening tests. Now, moving on, for those who are interested, I know that this is going beyond my topic already, but I couldn't resist including this slide from Dr. Roa's lecture yesterday. So if you're interested with regards to how to treat LTBI, here it says you can use isoniazid alone, rifampicin alone, or a combination, shorter, 3 to 4 months, or weekly rifampicin. I'm not sure though if it's already available, plus isoniazid for 3 months. So that's how to treat LTBI. Finally, our last issue for this webinar is, what if you have a person with diabetes and yet they smoke? What should you do about them? Apparently, both diabetes and cigarette smoking independently increase the risk of death in TB. So compared with non-smokers, current smokers had increased mortality from TB with a hazard ratio of 1.6 for men and the same for women. Estimating, therefore, the combined impact of diabetes and smoking yielded a hazard ratio of nearly 6. So you're 6 times at risk of dying from TB if you're both a smoker and you have diabetes. And therefore, advise all persons with diabetes, or actually practically anyone, to stop smoking. But the one with TB, the one with diabetes particularly, make them stop, because it will save their life. And finally, just the summary and conclusions for this webinar. Persons with tuberculosis always need to be screened routinely for diabetes in order to improve outcomes and prevent death from TB. Good blood sugar control is essential in ensuring better outcomes for TB treatment. Routine screening of persons with diabetes for latent TB is not yet though recommended, and we treat persons with active TB and diabetes similarly as those without diabetes, a 6-month course of anti-TB medication. So I just want to say thank you for all those doctors who I work with in one way or another, Dr. Mortera in the CPG, Dr. Iris for some of the slides on the CPG for diabetes, Dr. Tamban, who was with me in the Philippine Practice Guideline development for vulnerable individuals, especially the diabetic persons, and Dr. Roa for his slides on LTBI. So thank you very much for listening.
Thank you for a very interesting lecture, Dr. Jimeno. We have 108 participants logged in through our live streaming and 254 through Facebook Live. No? We would like to thank today's sponsor, Merck Sharp and Dome Philippines. We're now open for your questions or comments or insights on this problem. For live stream viewers, please type your questions in the Q&A box. For Facebook Live viewers, please type your questions in the comments box. Okay. So, okay na Cez? We can start. Okay. Let's start first with one of the first questions that was asked about whether an HbA1c of less than 6, I suppose, in a patient with with tuberculosis requires anti-diabetic medications.
Okay, I probably won't.
Okay.
That's if you're using the A1C, for example, to diagnose that person, I'll probably do an FBS also, but I'll take a look at where the A1C was done. But if the A1C is reliable and it's 6, I probably won't give treatment. I'll just monitor that patient. Maybe after you started anti-TB medications, I'll probably check the FBS, probably recheck the A1C sooner, knowing that, for example, the use of LNH would tend to increase the blood sugar a little bit. So I'd probably request for the A1C sooner than 3 months.
What is sooner than 3 months?
Maybe in a month.
Probably a month.
Just look at the
Will
trends.
it be different if the patient, for example, has a family history, very strong family history?
I probably still won't treat because that's actually an A1C of 6 is still quite good.
Yes. My A1C is higher than 6. Do you have an absolute threshold if you're talking about diabetes and tuberculosis?
I would. The targets are the same. You would try to reach less than 7 for most, less than 6.5 for some. In fact, if you're using the A1C for diagnosis and it's just 6, that means you're just barely. If you accept A1C as a diagnostic criterion, you've actually just made it to diabetes.
So, panalo.
Panalo, oo.
So, the goal is to keep them there, right?
Yeah.
So, I think you emphasized very much how much that we need to be really aggressive in treating patients with diabetes who have been diagnosed with tuberculosis as well.
Mm-hmm.
And one of the points you earlier said is try to normalize your FBS, your postprandial glucose as much as possible. And however, what I noted in the algorithm is that the reevaluation for whether or not they receive the goal target is 3 months.
Yeah.
If you have a patient with diabetes, do you evaluate and try to target it faster than that?
Okay. Because the treatment for TB is maybe 6 months, 9 months for some, you're in a hurry to try to keep up with the TB treatment, and therefore I probably because what I flash is for the general.
Yeah, that's for general.
For persons with diabetes. I'd probably be having them follow up more, have them monitor more often. So, for example, if the run-of-the-mill type 2 diabetes, they'll come back after 3 months.
Mm-hmm.
I probably will make them come back even in 2 weeks' time, actually.
Okay.
The first visit. But for most, maybe every month would be ideal.
Yeah. So we won't probably follow the wait 3 months and evaluate. Matatapos na yung treatment, isang follow-up lang siya.
And it's crucial that you get them to control at as soon as possible time. If you're going to wait 3 months, that means they're midway their treatment for TB.
And it's a lot of missed opportunities already, both for the treatment of TB and for the diabetes.
Because you'd like them to ideally be smear negative by the second month. So if you're going to just follow them up for their diabetes in the 3rd month, they will not make it to that smear negative at 2 months.
2 months. So let's remember that. No? So maybe in the big graph, we always remember evaluate every 3 months for whether or not they reach their target. But for patients who are being treated for tuberculosis, you try to do it in a month because you want them to be smeared negative in 2 months. Okay, that's the pulmo end of it. No? Another thing coming from that algorithm for the treatment in general of patients with diabetes, because there's an opportunity there for monotherapy if your sugars aren't very bad.
Yeah.
would you say the same if the patient has DM and has tuberculosis? So A1C is not so bad. Your capillary blood glucose is less than 250. Would you still try mono?
I would probably take a look at how the patient has been performing previously. If there's some consistency in terms of their sugar control for the past few months or years, they've been keeping at that, then I'd keep them on monotherapy. But if on the other hand, they've been erratic in their control, I would probably optimize and start them on combination therapy. If I find, for example, that their next FBS is higher than the baseline, I would optimize right away.
What if it's a new patient? So new patient comes in, referred by the general care practitioner.
Okay. I would
still... mga 230.
230, the blood sugar is 230. And they're just initiating the anti-TB medications. I would try to get an A1C, but if it's 230, I will already probably start combination therapy, even broach insulin already to that patient.
200.
Ang hirap daw.
Practical questions, right?
Well, 200. Sige. In general, 200 and below, kaya yan ang metformin.
So,
and that's why you'd have them come back probably in 2 weeks' time with the repeat FBS. If the repeat FBS in 2 weeks' time shows a trend of dropping, then the monotherapy should be fine. But if in 2 weeks it's still not there, remember in the algorithms, we only combine after monotherapy.
Yeah.
The soonest is in 3 months. Most of the time, we do it after 6 months. So here in TB and diabetes, we're running after time.
Yeah.
So I make them come back in 2 weeks. If it's not there yet or it's not dropping at all, I'll probably start combination therapy.
So we better get the target in 2 weeks.
Yeah, or introduce insulin.
Yeah. So, or otherwise, we need to be more aggressive.
Yeah.
So the timeline of 3 months, again, is actually abbreviated in the patient with diabetes.
Yeah.
We have some questions coming in. One of our listeners noted that most of the studies are cross-sectional. They're interested in whether or not there is a causal relationship between diabetes and TB, as in TB preceding diabetes or diabetes preceding TB.
I think the idea is it's bidirectional. It's really hard to say which, because both are very common in the Philippines especially. And so it's hard to say which one was ahead of the other. All that we can say, it's really bidirectional. So TB can increase your risk of having higher sugar. And on the other hand, having diabetes does predispose you to having TB, especially in a country like ours, we're very endemic for TB.
So the bottom line is 2 common diseases, they make each other worse.
Yeah.
We don't know if it's a chicken and egg thing. We just know that if you put them together, expect worse outcomes for both of them.
Yeah.
Okay. Ito, kaya mo ba ito sagutin?
Tingnan
Mahirap
ko.
to. Is QI along E-rod still functioning as a TB hospital?
Hindi na ata.
Parang hindi na. Kasi ang taas na ng tala.
Let's ask
You will
Juber.
call a friend, okay? Okay, so here, question. If ever you have a category 2 patient who completed treatment, but later on you develop on X-ray and sputum, so hindi siya nag-smear negative, how do you treat daw?
Well, apparently, according to this, if they had retreatment, let's say they completed treatment, and then let's say they were category 2, which means their retreatment, they completed it. And then after they successfully completed it, they come back again and it's again smear positive. Then you need to think about whether this is in fact drug-resistant TB.
So it's a treatment failure, essentially.
It's a treatment failure. And so you need to think about whether it really is in fact drug-resistant TB. And for that, you need to take, of course, the cultures. You need to refer now to centers that are treating for MDR and even XDR TB. No?
Yeah,
so there's no clear answer to that. And all I'm saying is if you've adequately treated, the retreatment was completed, you've even documented, for example, in chest X-ray improvement, they're smear negative, and then it's back again, maybe you need to consider that it might be drug-resistant TB.
Yeah, just a reminder to everyone, the references that were used here are all open access.
Yeah.
So we can always refer the CPG, but there's always gray areas in that CPG about difficult cases like this, and that's what our friends in Pulmo or ID are waiting for. They're excited about XDR. Okay. Ito, tanong. Pwede po bang mag-stop na ng maintenance for diabetes if consistent na pong normal ang sugar due to lifestyle modification? I think it's because the first step is diet and exercise. So if you hit your target,
those patients are rare and uncommon, but I have had patients who have been very good and very adherent in their lifestyle modification. They really kept the weight off. Yes. It is now possible to be off medications even if you do have diabetes. So there are many success stories like that.
Nangyayari ba yun kung may TB?
Not for TB. Okay. The general rule is they're all on medications.
Yeah. But TB can be treated, and perhaps after the TB has resolved, they can go back to their diet and exercise regimen. Okay, this is for you. How to better treat patients who are non-adherent at all. So they've had this physician has had a patient na nag-below knee amputation na, tapos ayaw pa rin maggamot ng maayos.
Sige. There are many approaches, but these kinds of patients who are not motivated to get better, there are probably many issues that are going on. I'd probably assess psychologically, is that patient does that patient have some form of depression? How come he is not motivated to get better? How is the family support? I do like to include the family in improving adherence, especially not just to drugs, but to even lifestyle modification. Just like the OT. It's the same in diabetes. If you can get the family to help the patient become more compliant. Those are some of the tricks that I've had. One is involve the family. If the husband is the one who's sick, the wife is the main main point person. And then secondly, assess them as maybe there is something else that's going on. And depression is quite common in many chronic diseases, including diabetes.
That's right. And you really have to befriend the family because, you've had instances where the husband would say, alam naman yung bawal, that's what the family prefers, right?
Yeah, it's very hard. I cannot imagine actually how they're doing it in families. Let's say the mother or the father has diabetes and the rest of the family has to eat. I don't know what they do with their food. Maybe they're cooking the same food for everyone, but measuring it out for the parents who have diabetes. But really, family support is very important.
Yeah, we've all had stories about patients say, my family loves ice cream and they all have ice cream and what am I supposed to do? Stare at it.
And the parents or the grandparents, diba, it's our culture, we like to eat the leftovers.
That's expression of love. So, going back to the issue kanina, we said we start, if the HbA1c is less than 7.5, we can start out with diet and exercise in the general population.
Yes.
What about patients with TB?
In patients with TB, if you find an A1C less than 7.5, I would check the FBS. If the FBS was higher still than, let's say, 126 being the threshold, I talk to that patient and try to motivate them to at least start monotherapy treatment for meaning, if you start them on drugs, choose a drug that is not likely to cause adverse drug reactions when the blood sugar is not that high at baseline. And that drug, which has the least adverse drug reaction and cheapest, is metformin. But you can also choose the newer ones, like the DPP-4 inhibitors. They also have very minimal adverse drug reactions.
So again, the threshold is a bit lower in terms of treatment for patients with TB. This is a common issue because a lot of patients with TB also have some form of renal impairment, right?
Yeah.
So how do you work through that?
That's difficult. They would probably avoid giving, of course, the drugs that are nephrotoxic from the outset. And that's why many of these patients who already have renal compromise from the beginning need to be under subspecialty care.
Yeah.
So the nephrologist probably has to come in early to help you to adjust the drugs and working with the TB specialist.
Yeah, probably we'll need to help each other out in scenarios like that. The questions are starting to flood in. Okay. This is a person working with children with intellectual disabilities. How do you collect sputum? Oh no, that's really hard. We'll reserve that for another webinar, and that's probably an interesting question. How do you handle it for patients with some cognitive issues?
Alam ko what they do is, because we used to do that when we were interns, gastric aspirates.
Yeah. Naaalala pa natin. Okay. Do we use Gene Expert routinely?
I'm not a pulmonologist, but I know that they do. Gene Expert is widely available now throughout the country. Yeah. I do know that it is widely available.
Do we have studies on Gene Expert? I think this is supposed to be positivity or findings among patients with diabetes.
I don't think we have any specific studies on that. We just did a prevalence study among our patients in PGH who were following up in the DOT. And we found the same prevalence of diabetes among these persons with TB.
Okay.
Around 20%.
This is interesting. In a resource-limited setting, if you need to diagnose GDM, can you use FDS instead of a 2-hour OGTT? And if A1C is not an option and they use FDS, how often do you suggest that we monitor it?
Okay. So the first question is gestational diabetes. Unfortunately, the FDS is not a good enough test because gestational diabetes is a state of relative insulin resistance, and it's best, therefore, to diagnose it using an OGTT. Now, if in your locality, and I don't know why it wouldn't be available, because you only add lang naman the anhydrous glucose. And it's readily available in many of the laboratories. No? And very soon, I think, with the guarantees in PhilHealth, all pregnant women will get screening for OGT.
We have 4 minutes left. So can you use metformin to prevent acute cardiovascular sequelae and delay diabetes? I think that's another issue we can talk about.
But
for our
if you want, last year I had a webinar on pre-diabetes.
Okay, so
if you want to view that in 2018, we had a webinar on pre-diabetes.
Wow. Okay, that has certainly been a very lively discussion. Thank you for that, Dr. Jimeno. To summarize, we'd like to emphasize the following point. We're talking about the intersection of 2 common diseases, TB and diabetes. We know that the risk for TB is higher among patients with diabetes, and patients with diabetes are at a higher risk for tuberculosis. Therefore, we need to screen all DM patients for tuberculosis, because it's an immunocompromised state. And we also need to screen all patients with TB for diabetes, because we would expect worse outcomes. And if we do find the intersection of both, we will need to treat the diabetes more aggressively, and that will probably entail the use of insulin. Easy numbers to remember: basal is 10 units per day. Add 1 if you're not hitting your targets, and you check on targets using your capillary blood glucose. So, pwedeng tinutusok-tusok, pwedeng dito. But however, you treat the TB the same way as you would treat other patients with TB. LTB, no need to screen for patients with diabetes. But sa amin, uso yan. Kasi ruma ako. Okay. So thank you for that, Ces. So after this section, the link to the evaluation form will be emailed to the email address you entered in the attendance form. Please answer it immediately to get a copy of your certificate a week after the webinar. Webinar recordings of our previous webinars are now available at the UP Manila official YouTube page. So pwede nyo pong ulitin yung mga talks. You may access the following webinars through the link flashed on your screen. Thank you for joining us. Again, we would like to thank our sponsor, MSD Philippines, for their support to this webinar. We hope to see you again in our upcoming webinar on March 20, Wednesday, same time, 12 to 1 p.m. Manila time, with our speaker, Dr. Regina Burba, entitled Antimicrobial Resistance State of the Philippines. Where are we now? She's our PCP awardee for research for the year. Again, this is sponsored by MSD Philippines. Please invite your colleagues to join this continuing weekly CME webinar series. All schedules and resources will be posted at the following Facebook address. And you can also email us for any inquiries at the email address that is on your screen. On behalf of UPCM Class 1994 and the UP Medical Alumni Society, we would like to thank our collaborator units, UP College of Medicine, Postgraduate Institute of Medicine, the UP Manila Information Management Service, and the AEHIN. Please join the 2019 Aging and Longevity webinars every second and last Friday of the month. And you're also invited to the first of a two-part Lenten webinar series by Father Gregory Gaston this coming Friday, March 22 at 12 noon. This is Dr. Reyes with Dr. Jimeno, who deserves a big round of applause, and the UP Medicine webinar team. Thank you, ladies and gentlemen, closing this session. We hope you have learned a lot from today's webinar. Join us again next week on March 27. We'll see you there.